Hi, everyone. I'm Elizabeth Klimak. I'm here at the Fox Chase Cancer Center in Philadelphia, where I am Chief of the Division of GU Medical Oncology and I direct GU Clinical Research. And it's an absolute honor to give a patient talk at this year's KCA meeting. And I thank the Kidney Cancer Association for inviting me to speak to you all. And I was asked to speak on Kidney Cancer 101, and I sort of retitled it Understanding a New Diagnosis of Kidney Cancer. So obviously a new diagnosis of kidney cancer hits each of our patients as a shock, but winding through the initial diagnosis and decision making is something that I think we at KCA can help with. So I'm happy to be sharing this presentation with you to hopefully add a little bit of guidance to your journey. So here are my disclosures, and they're also in the KCA literature. So here's the first question that most patients ask, and if they don't ask me in clinic, I know they're wondering it. Why did I get kidney cancer? And the real answer for the vast majority of our patients is just random bad luck. So the cells in our body divide many, many, many times during our life. Any mistake in one of those cycles can cause a mutation that leads to cancer. So I think many of us can speak back to our days in medical school when we learned about how cancer starts and being surprised that actually there isn't more of it than we see, because it just seems so easy to have a random mutation. Fortunately, it's not that common, but if one has one, it's just to know that it's probably nothing you did or nothing you were exposed to. The caveat to that is there is an increased risk of all kinds of cancer with smoking or exposure to other carcinogens. So if you or someone you know smokes, quit and encourage them to quit. Is kidney cancer genetic? So the answer to this question is almost never. There are some uncommon types of kidney cancer that can be genetic, and if you're seen at a specialty center, your doctor will know if you have one of those and refer you to clinical genetics. But don't automatically assume your children are at increased risk for kidney cancer. Most likely they are not. I have kidney cancer. Does this mean I will need dialysis? Another common question that we get, I would say not usually. Very few of our kidney cancer patients ever need dialysis. We all have two kidneys, so even if one is removed in order to remove the tumor, the other can usually do the work of both. And important to know is your kidney function is determined by a blood test called creatinine. That's how we can tell how well your kidney or kidneys are functioning. It's not by how many kidneys you have. So someone with two kidneys could easily have worse kidney function than someone with one. And that's important to know because if you do have one kidney, and many of our patients do, you may still be able to take drugs like ibuprofen or get intravenous contrast with your CT scan, as long as your doctor is monitoring that blood test creatinine. What kind of doctor should a newly diagnosed kidney cancer patient see? Well, we all work as a team, and here's a list of the 3 more common doctors that one would encounter in the beginning of their kidney cancer journey, but there's certainly many more roles that are filled by other specialists that we collaborate with. So the first is either a primary care doctor or an ER doctor. Most commonly are the ones to diagnose kidney cancer first. And that's because kidney cancer usually appears after testing done for symptoms. And those symptoms can either be related to or unrelated to the cancer itself. One of the common presentations we see of kidney cancer is what I call a lucky kidney stone. Someone who has a kidney stone, we image them for that, but find a small curable kidney cancer that can then be removed by surgery. So sometimes it's what's called an incidental finding. Sometimes kidney cancer itself can cause symptoms: weight loss, pain on the side of the kidney tumor, blood in the urine. Those symptoms sometimes are what tip us off that kidney cancer is present. But there is no screening test for kidney cancer, and so it's not something we can reliably watch for. The reason for that is there's no test that's good enough at picking up enough cases to make it worth recommending to the general population. So 2 other types of physicians that a patient with kidney cancer is likely to meet. One is a urologist. These are surgeons specialized in the surgical treatment of kidney cancer. They can arrange for further testing, such as a biopsy, and they can also remove kidney cancer surgically if it's in the kidney or adjacent areas. The next is a medical oncologist. I am a medical oncologist, and we treat kidney cancer. Generally, kidney cancer that has spread is where we come in, And we use drugs and other new novel treatments to shrink it back or slow its growth. So let's start with localized kidney cancer. And here's a nice picture on the right of your kidneys. You can see they're on either side of the two great vessels in your body. They sit under the diaphragm and under the lungs. Here on the left kidney in this individual, the right on your screen, on your slide, is drawing of what cancer would look like that is confined to the kidney. We do stage cancer, stage 1, 2, 3, and 4. I find that, however, much more useful to clinicians than to patients. I think the key differentiator from a patient perspective is the kidney cancer localized to the kidney? Is that the only evidence of presence of cancer is in that kidney, or is there apparent spread to other areas? And that's the difference between stages 1, 2, and 3, confined to the kidney or adjacent area, or stage 4, which is a distant spread. So kidney cancer that is only in the kidney, if there's no evidence of spread, can usually be cured with surgery. Now that's very dependent on multiple factors. It's a very specific analysis to your situation. Your doctor would order advanced imaging, look at that, examine you to assess whether he or she can remove it surgically or cure. After surgery, your doctor will order periodic imaging, usually with CAT scans, to make sure that that cancer hasn't grown back. And that's how we approach, in general, localized kidney cancer. Right now, we don't have any approved or recommended treatment to use for someone who's had surgery with no evidence of cancer to prevent it from coming back. We do sometimes use chemotherapy and other drugs in other cancers in this fashion, but this is not our approach to date in kidney cancer. Trials for this, investigating this, are ongoing. So what if my cancer has spread? So each type of cancer is named from where it was born or where it originated. So patients with kidney cancer, the cancer always starts in the kidney, but it can spread to other areas. Kidney cancer that spreads, for instance, to the lungs is still kidney cancer. It's not lung cancer. And this matters when your doctor is selecting your treatment. It also might matter who you see for treatment because, for instance, here at Fox Chase or other specialty centers, I specialize in kidney cancer, no matter where it's spread to, but my colleagues down the hall are the ones who would see the patients who come in with a lung cancer or a colon cancer, for instance. So again, it's important to know that kidney cancer is what it is, even if it's spread. So as of today, sitting here speaking to you now, kidney cancer that has spread is generally not something we can tell patients we can cure. I put an asterisk by that, not on the slide, but in principle, only because we are always seeking to cure patients, even in whom it has spread. We sometimes have very, very good long-term control. We don't yet know if those are cures. So I think it's something that your doctor will tell you generally if you have kidney cancer that's spread, we can treat this, but unfortunately we can't cure it. So treatments for cancer that has spread or metastasized are focused on shrinking and slowing the growth of the cancer. Sometimes we're capable of shrinking it down to nothing. Sometimes we keep it where it is for many, many years. But no matter what the result of the treatment, they can be effective for variable amounts of time. And we hope for each patient that the treatments they're on will be effective for many years. And so why do we say years? And that's because since the early 2000s, we've really evolved the treatment paradigm for kidney cancer. And we are drastically improving, especially in the last 5 years, the percentage of our patients who are in this particular graph alive at 2 years. So you can see a little over half of our patients for a number of years. And then with the addition of more newer agents and combination, we're now up much higher. We would love to get that number up to 100%. We're working on it. But we have made progress and continue to do so. In terms of response rates, I'll tell you what this term means in a minute. We have also made improvements. And here are all the different tests, the studies that we've done with different agents. Right now, the ones we use most commonly for a newly diagnosed patient whose cancer has spread, metastatic disease, are the two circled here. A response rate, when you read about these in the literature or hear about them, means the percentage of patients whose tumors, when we look at them and measure them on a CAT scan, have shrunk more than 30%. So not included here are patients' tumors who shrunk 29%, 25%, 5%, or patients whose tumors have grown. So these rates represent one piece of what we look at when we're evaluating treatment in terms of whether it's a good one or an improvement on what we had before. Another thing you may hear about, and this is a little bit getting in the weeds, but your doctor, when you come in with a newly diagnosed case, will assess your IMDC risk. And this is just our way of using what we know from the literature to see what treatment is right for you. The risk criteria are determined based on standard blood tests listed here on the left in pink: hemoglobin, calcium, platelets, and neutrophils. Performance status, which means how well you're doing, how well you're functioning in your day-to-day activities, and time from initial diagnosis to treatment. For a patient who had their kidney removed 5 years ago and now has spread, that's different than a patient who comes in with cancer in multiple areas of the body to begin with. Most of our patients have one or more of these risk factors and fall into this intermediate or poor risk group. I will add this as a prognostic characteristic. This does not necessarily determine you will do badly with treatment. So really important to stay optimistic no matter what category you're in, because treatments work for all these categories. But we do select treatments and counsel patients a little bit differently depending on their risk. So here is what the risk criteria look like. I use this a little bit to talk about risk criteria, but also mostly to share with you that we look at Kaplan Meier curves a lot in cancer. And if you see these, I'll just quickly do a tutorial that starting at the left of the x-axis is 100% of our patients at the very top there where all the curves start. And then as time marches on along that x-axis, you can see some patients die, and the curves represent the number of patients still living at the time of the analysis listed there. So what I say in medical oncology is we are always trying to push those curves up toward the sky to have everyone living for as long as possible. I'm happy to say we have succeeded in doing that in certain treatments. We're not 100% there yet, but we are improving year after year. So I'll walk through a case. I purposely selected 2 cases of patients who did very well, again, to sort of put some optimism out there, but these are real patients who I've treated in clinic. So we'll speak first to a patient who had favorable risk. So this is a patient who presented when she was 70. She noted blood in her urine and found a tumor on the kidney. There's no evidence of anything else, so the kidney tumor was removed surgically. A year later, her CAT scan showed a single tumor deposit in the lung. Since it had been a year, we removed this with surgery also. This is something we sometimes do for cancer that's slow growing where there's a long interval between surgery. 2 years later, so now we're 3 years from her initial surgery, imaging showed slow growing deposits in multiple spots in the lung. So again, because of this slow growth and with the patient's permission and sort of encouragement, we decided to observe these. They were growing so slowly, we didn't feel we needed to treat them right away. So after 3 years of this slow growth, we noticed also an abnormal lymph node. And then based on this, we decided together to start treatment. She had favorable risk, so a good prognosis. And we know that because of the history of her cancer so far, that it was moving slowly. Here's a list of all the things we think about for this group of patients. These are all the available approved first-line options in the United States. I only list these here not as a quiz for the group here, but to say that your doctors are considering lots of different options for you when you come in newly diagnosed. And seeing someone at a comprehensive cancer center with expertise in kidney cancer is probably really important because there's some nuance into how we think about and select these multiple options of treatment. So she was treated before we had combination therapy available, which would be probably what we might recommend to her now. But she was treated with a pill called pazopanib, 600 milligrams once daily. She had some side effects from this. I use acronyms here, but that she had some sore feet, high blood pressure, and the beginnings of liver damage with abnormal liver function tests. So let me digress here for a minute and talk about how we manage side effects. Here's a patient, we picked a treatment, we started it, and I should say she's doing well on it, her tumors were shrinking on it, we wanted to keep her on it. When we talk about managing side effects of the pill-based treatments, these are called VEGF inhibitors. It's a category of drug that your doctor might talk to you about. These are all the different things that could happen. Nobody gets all of these, but we don't know, sort of randomly, we like throwing a dart, we don't know who will get which. You can get diarrhea and fatigue. In this hypothetical case, our patient here had hand-foot syndrome and hypertension, but we don't know when we start what they'll get. And so because of this, it's really important that you tell us what you're experiencing. So once you start treatment, we ask you to keep a diary of how you're feeling, including a daily blood pressure. If you have early bothersome side effects, call us. We've seen them all before, and we can help you manage them. We usually book our patients at 2, 3, or 4 weeks after they start for blood work and detect any side effects or blood abnormalities early. And please know, when side effects start to emerge, your doctor might hold your pills for a few days and restart you at a reduced dose. This is not defeat. It is important to use exactly the amount of drug you need to control your disease and allow you to live with the most minimal amount of side effects possible. So don't give up on treatment just because the first dose your doctor tries is too much for you. But do not be a hero and continue with side effects, even if they're so bad, waiting until you just can't stand it anymore, because that doesn't help in the long run either. So now our 74-year-old woman had a CT that showed shrinkage of her tumors, but she continued to have side effects even at the lowest dose. And so after some time, we decided to continue pazopanib. And here's the list of all the next line options that we think of when we see patients like this in our clinic. And again, you can see there are many, and there's nuance to why we select these. So again, seeing an expert to help select is useful. For this particular patient, at the time she was treated, we selected a similar pill-based therapy called axitinib. So how do we select these things? What do we do? Principles, here's how we think about it. If a cancer is well controlled for over a year on a pill-based treatment, we look for similar treatments in the same category. If the response to this initial treatment was very brief, we consider a combination therapy listed here. If there's no response in the first line, we drop that and move to something totally different. For instance, a primarily immunotherapy-based approach. And beyond that, we have other options, including clinical trials or a nice combination of 2 pills, lenvatinib and everolimus. Everolimus is a different kind of pill. So this is just a very general overview, again, just so you know what your doctors are thinking through when they're picking their treatments for you. So this patient, I'm happy to say, is 80 now, 10 years later. She started this axitinib at 3 milligrams, that's about half dose. And after a year, we reduced it even more for low-grade side effects. So even minor bothersome side effects, when you've had them for 5 years, can be wearing, and that's what happened with her. So we reduced her further. I'm happy to report she continues on the lower dose. Her cancer is stable and asymptomatic now, 6 years on this particular drug. So this patient had 10 years of disease control with observation, surgery, and just pill-based treatment so far in terms of her kidney cancer. And if we need additional treatment for her, we have it in our pocket, because during the time she was treated, we've invented many new approaches for her. Okay, let's move on to another case here. This is a patient with intermediate or poor risk kidney cancer. And again, this is the majority of our patients. It's just even one blood abnormality can put you in this category. It just means we usually turn to combination therapy first. So here's our case. This is a young gentleman. He's 40 years old. He has clear cell kidney cancer. He had his kidney removed. The goal was to cure him. But 9 months after that kidney removal, he was noted to have recurrence in the lungs. He also had low hemoglobin. The rest of his counts were normal. And he was starting to sort of not be able to get out of bed, do things he needed to do, meaning his performance status, his functional status was only 80%. So based on this, he fits the criteria for poor risk kidney cancer. And he started on our clinical trial of axitinib and pembrolizumab. And this is one of the first trials of this combination, which is now something we use regularly. Thanks to him for being part of the trial that proved it was effective. So when we think about selecting first-line treatment for this particular group of patients, the list is a little bit shorter. We really lean on combination therapy, either axitinib or pembrolizumab, as this gentleman received, or pure immunotherapy, ipilimumab and nivolumab. He is now 44. He's actually probably now 45 since I did this slide. He is treated on the clinical trial, of axitinib and pembrolizumab. This is the typo here. He had near resolution of his lung metastases at the first scan. Pembrolizumab was discontinued at 2 years. So we felt he had enough treatment and he could stop. He didn't want to stop the axitinib, so he stayed on that for an extra year and a half. But at 3.5 years, when his cancer was really stable and probably, you know, shrunken down to just the scar of where it used to be, we, you know, screwed up the courage to stop treatment altogether. And I'm happy to say his scans continue to look stable and good. So he asks us, how long will my cancer stay controlled? That's the question we can't answer. When we talk about cure, is this patient cured? He's completed treatment. He doesn't need it right now. Could it come back? It could. We'll follow him and we'll learn from him many things that'll help us treat the next generation of patients who are diagnosed with this disease. So one of the things we talk about a lot is treatment-free survival, like this gentleman is experiencing now. He's off treatment, he's living life, he's not having any side effects from treatment, and his cancer is controlled. And we're starting to measure this more and more in patients on trials. And I show you this graph. This is just an example graph. It was from a recent presentation that shows you, again, these are the Kaplan Meier curves. This dark blue spot here, these are patients who are off treatment alive without any adverse events. And you can see in terms of percentage, it's only about 10% of the total population of patients treated. Many years later have died, but many are still alive. These colored bars are patients who are still alive, either in purple on treatment or in blue off treatment, the dark blue being treatment without any side effects or treatment-free without any side effects. So we really want to grow this piece of the curve, this sort of dark blue ribbon of the curve. We want more patients to be alive and off treatment after successful treatment of kidney cancer that spread. And someday we hope we might even call that a cure. So in conclusion, until we can cure kidney cancer, our goal remains to keep our patients alive and feeling well for as long as we can. With many choices in advanced kidney cancer, careful consideration of multiple factors is required at each decision point. What is the rate of growth? Can it be observed? What is the risk category? Other health conditions are important to consider. So autoimmune diseases, vascular diseases can increase the risk of certain treatments and make us lean towards other alternatives. And importantly, what do you, the patient, prefer? What are your values? What is important to you? And how can we craft your treatment around that first and foremost? So following patients on treatment for many years or patients who stop treatment, we do this mostly in the context of clinical trials. All this will give us valuable information. So I thank you, our patients, past, present, and future. New treatments are only possible through clinical trials, testing and approving new agents to help people live longer and better with this. And I thank you and all our patients who participate in kidney cancer research, either by donating tissue, blood, data, or participating in clinical trials. And I think together we are working towards a cure. Thank you.